Okay, hello.
Okay.
This is Abeer Alghofaili from Saudi Arabia. I'm optometry specialist at King Khaled Eye Specialist Hospital. I have a master's degree in investigative ophthalmology and vision research. So today presentation, we are going to describe how soft contact lenses are used for irregular corneas. We are going to describe the features and the benefit of Kerasoft IC Design. We will go through an overview of fitting process. Now, contact lens options for keratoconus includes all these modalities that you can see here. We have got corneal lens, scleral lenses, and hybrid lenses. And one thing that all have in common, and they have a rigid gas permeable optic zone, and that rigidly provide a nice, smooth, refracting surface, almost an artificial corneal present underneath the rigid surface. The space between the irregular cornea and the back surface of the lens is filled either with patient's own tears in case of corneal lens or hybrid lenses, or they are filled with supplement-free artificial or saline, like in case of scleral lens. And what the liquid does, it fills the gaps between the irregular surface and the back surface of the optical system. The back surface of the lens, the irregular surface of the cornea, and the back surface of the lens, and that create one optical system. And so it's make the irregularity, and that's how the patient is able to achieve their visual rehabilitation with these lenses. So how do the soft contact lens fall into play? We are going to describe the traditional soft contact lens and just to highlight what's unique about the Kerasoft IC lens design. So why would you consider a soft contact lens for your irregular patients? Well, one main feature is the lens intolerance. I mean, we have all had those patients that have the perfect GB fit for their keratoconus, and they just cannot tolerate the lens for even a minute in their eye. And so what do you do with those patients? There are also problems with hybrid lenses where sometimes they have a problem removing the lens. And you know, in scleral lenses, they can be a little intimidating for patients, whether it's a size or the cost of the lens. So soft contact lenses provide excellent comfort, like we already know with our traditional soft lenses. And the other thing too is that, you know, all the irregular patients, the irregular cornea patients really benefit visually with a contact lens. We know that their spectacle vision is apart, and sometimes it's not even functional for them. So how they actually work is that they are designed to fit whole cornea, so not just the cornea and the lumbus, but they also rest on the sclera. And what they have to do is it allow the optics to be centered. So if we think about GB corneal lenses, typically you have your optic zone, but optic zone that only houses the optic for the patient. It also houses that fitting curve, and so the fitting curves is going to fit over the steepest portion of the cornea. It's quite rare, but that the steepest portion of the cornea and the keratoconus is actually centrally. So oftentimes the apex of the cornea is displaced, taking the GB corneal lens optic with it. So that can be rather problematic for your patient, especially with a low cone and small diameter lens. They may not be getting the benefit of the object, so soft contact lens do provide a nice central optics. Now, soft contact lenses irregular have been around for a little over 30 years, and how they actually work is almost mimicking the effect corneal lens of corneal lens or the GB lens that we talk about. What they employ is increasing center thickness in order to increase the rigidity of the soft lens. And so as a result, tears pull underneath the soft lenses and create that making effect. Then some of these lenses are also really only available in hydrogen materials. So with the low decays of the material and increasing the center thickness, we are really reducing the maximum amount of oxygen that's reaching the irregular cornea that we are trying to. So when we think lens materials options, like I said, that hydrogen materials are ranged between 38 to 59% water content, and the decay range from 8 to 34. So again, when we are increasing the central thickness to create a rich effect, what ends up happening is we end decreasing the amount of oxygen that's reaching the cornea. Now the Kerasoft ICU lens uses a silicon hydrogen called a definitive that has a decay value of 60. And this is what a nice feature, and is a kind of sets this lens apart, at least for oxygen permeability. Who are the candidates for soft lenses with irregular cornea? Well, typically we think of keratoconus, and we have the whole family of naturally occurring ectasias. We have early onset keratoconus that does quite well with this design. So the younger children and the adults that are starting to present with a keratoconus or some steepening from the first keratoconus, and those patients are detected in a refractive surgery center that may actually be experiencing some glare and shadowing. This lens can also be helpful for those patients. We also have a pulsed marginal degeneration and keratoglobus as a part of naturally occurring ectasia. Now, those patients that had the naturally occurring ectasia may have already underwent some form of surgical correction, such intacs, ring implants, or corneal cross-linking, and these lenses can also fit over those type of corneal patients that underwent refractive surgery and have a poor outcome, typically post-LASIK ectasia patients, or radiokeratometry of patient that they are also candidates for Kerasoft IC lens. Corneal transplant that can be really tricky to fit because they are unpredictable. You don't have a predictable curvature of the cornea, and so that can make a corneal lens fitting in injection can make a corneal lens fitting in particular very challenging with a lot of instability and sometimes harsh peering of the craft house junction. And lastly, the really important features of this lens for irregular cornea, it's a comfortable lens. So for those patients that suffer from this particular condition that I mentioned here, if they are already intolerant to whatever lens modality they have, that is a rich lens, whether it's a hybrid or corneal GB, or they just are not ready to try a scleral lens, they make a really good candidate for Kerasoft IC lens. So really important, not just with a Kerasoft lens, but any type of lens correction for irregular cornea, you should know what you are knowing, what you are working with. You need to understand the cornea shape that you have. So here we have represented topographies and OCT images. For irregular cornea, starting on the left, we have pulsed marginal. The first one we have a typical with a rule normal cornea for comparison, and I think it's really important to look at here. As we have, when we are looking at the keratoconus and PMD, you can see where the steepening is occurring. But I would like to draw your attention is that the superior aspect of this cornea and the keratoglobus here is not a little bit of exception, but when you look at the keratoconus and BMD, the superior aspect of the cornea really is not that much different than the normal cornea. The reason I'm bringing this up is because like I said, all the soft lenses for this category fit over entire cornea. Using Kerasoft IC lens, you are going to be using flatter base curve than you traditionally think of when fitting irregular cornea. And that is mainly because you are not just fitting the steepest portion of the cornea, you are fitting the peripheral cornea as well. So that is not that uncommon to have a base curve of 8.2, 8.4, or even 8.6, or even flatter when you're using the Kerasoft IC lens tool. And again, these base curves are very similar to what you fit with a soft sphere if you have standard myopic coming in your clinic. So let's talk about the Kerasoft IC lens design. It's designed to fit all stages of keratoconus and other irregular cornea. I want to mention that the IC of Kerasoft design mean irregular cornea. So the Kerasoft IC lens draped over the cornea rather than using a thickness of material to mask the irregularity. So in this case, we don't want to have excess tear pooling underneath this lens. So this lens is really meant to drape over the irregularity. As a result, you will have a cylindrical component come through in your over refraction. So this lens is a kind of a very powerful soft toric lens because you are able to put the cylindrical component into the correction of this lens. And this slide, there are all of the parameters of Kerasoft IC lens. The base curve, again, I'm just going to highlight some of the features here just to put in the context of fitting. The steepest base curve is 7.4. So again, we have to remember we are no longer fitting the apex of the ectasia. We are fitting the overall cornea shape. So again, we are going to be using a flat base curve, as you can see from the parameters listed here. The standard diameter is a 14.5 millimeter, and it's the fitting set, but it can be made smaller or larger than 0.5 millimeters steps. So now the reason that the lens correct the irregularity is because the front surface optics, they use a front surface aspheric and aspheric optics, and that's what create the optical. It's taking the irregular astigmatism and make it more regular, and that's how you can correct it with the front toric optic available in this design. The lens is stabilized with a Brisson balance, and another features is the peripheries can be steepening or flattening independently of the overall base curve. So what's nice is we have those challenging corneal transplant, for example, and oftentimes they have an oblate profile, so that means they are flatter in the center, flatter in the center, steeper in the periphery. So if we were to fit a corneal GP lens, there would be a lot of edge lifted. So sometimes we would fit to reverse a geometry corneal GB lens on this type if shape will with the shape will the soft lenses also can be created in reverse geometry. Typical profile, you can change the peripheral curves of this lens steeper than the base curve, or even flatter in the case of nipple cone with a flat periphery. The power range is pretty extensive, and the cylindrical component here is also extensive. And I know that a lot of time we shy away from providing the highest cylinder power when we're fitting with a standard soft toric lens for our astigmatic patient. However, with this lens design, we want to actually provide the maximum amount of cylinder power that we will refract. The patient will achieve their visual benefit in doing so. The material, as I said before, the definitive material and the DK is a 60. This is the silicon hydrogen material in this lens. The trial set is an 8-month trial set, and what I would like to focus on is the core lenses, which are the first 6 lenses that we see here for 7.8 to 8.2, 7.8 to 8.8 standard lenses. So again, the power is a plano of all the lenses, and the diameter is a 14.5, but this can be customized when you order that. The standard periphery pretty much fit most of the patients that you will be encountering when you are using this lens design. Now, to go one step in this design is 0.2 millimeter of radius difference. So going from, for example, from 8 to 8.2 is one step flatter in periphery. And the reason I'm bringing this up, or not just to the periphery, is just one step flatter in the lens, is because we have the last 2 lenses, which are these unique lens for those different corneal shape that you encounter. So remember, I was talking about the reverse geometry type of lens that you can create with the Kerasoft. Well, in the fitting set, you can actually have a reverse geometry lens that you can use. This is an 8.6, is still relatively flat base curve with a steep 2 periphery. So what that means is that this lens in the center, the base curve is 8.6, but a periphery is equivalent to 8.2 standard lens. So you are kind of mixing and matching your two trial lenses into one, and so I would use that lens in case of cornea transplants or those oblique corneas from refractive surgery that had their refractive surgery, whether it's a PRK or whether it's a post LASIK. Our post PRK, while they do have an inferior ectasia that is steepening the overall cornea profile is oblique. So 8.2 flat 2 lens in this in the lens set. So the 8.2 is relative steep based curve, and the flat 2 is equivalent to 8.6 periphery. This is the lens that you would actually use on the central nipple cone with a more flat cornea periphery, and we will describe in the fitting step and how you would actually determine when you would use that lens. So then we are going to just go through an overview of the fitting process. First, you want to determine your overall corneal profile and shape, and that is going to, with the help of fitting guide, help you select your first initial diagnostic lens. Now, when you apply the diagnostic lens to the eye, you are going to be using what is called the dynamic assessment technique using. So when you are observing the corneal profile, you can do it in 2 ways. You can use the slit lamp, or you can just generally look at the profile outside of the slit lamp. If you're using the slit lamp, you can see the housing of the slit lamp particularly to the patient's face. So this way you can get an actual profile view. And what you want to do is you want to determine where your steepest portion of your cornea is. So you want to see if the displaced from the visual axis is, if the cone is a central, is it a low cone as a PMD. Then the next thing you want to do is you want to look at the overall cornea shape. And again, I typically use the superior aspect of the cornea because it's just a little bit more normalized than if you run into issue looking at the inferior aspect in the case of low cones. And we all know that typical corneal shape looks like a normal patient. We have a feel for it. So you can actually tell when you are looking at the corneal shape, whether it's steep or flat, with a reference to what we are almost familiar to looking at. So once we have determined the profile, we also can determine what shape we are working. So we have We have topography examples, and they break down keratoconus into a central keratoconus with a steep periphery and central keratoconus with a more of a flat periphery. We have the low decentered cone as well as a PMD, and here they have an actual corneal profile, so you can kind of engage what they consider mild. Moderate, and advanced, just by looking at this profile. Because this particular image is in the fitting guide, and this is what is going to help, you select your first diagnostic lens, and lastly we have a post-surgical eye, whether it's transplant or posterior refractive surgery, that is have a reverse geometry profile, that tubular type presentation, and that's when you would use the 8.2 diagnostic lens that's in your set. So here is the initial lens selection guide, and so there's a lot of details on this slide. But again, if we are just looking at the mild category, you can see here that you start with a small. You start with the same lens across all the category, that 8.6, 14.5 standard lenses. So again, 8.6 is the base curve we are used to thinking about when fitting standard soft lenses. So we just have to remember, just because our corneal curvature is steep, we will not jumping to 7.8 lens in the diagnostic set. We actually have to just think of that we are fitting the whole cornea using Kerasoft lens, and remember, when we want this lens to drape over the cornea, we don't want any extra tear pulling under this particular design. So once we select the lens, then we put it on, and I like to take a look right away as soon as the lens is applied to the eye. And what we are looking for is just generally it's centered on the eye. We want to be sure there's no bubbles. If there's any bubbles that is located under this lens, we can push it with the lens up or try just to remove these bubbles. Now, if you can't remove those bubbles after your initial application of the lens, that is too suggested to the lens that you selected may be too steep for this patient. So you may want to go back and try a flatter lens from your diagnostic lens set. The other thing I'm looking at is if there's any edge floating. This we typically will see with a corneal transplant patient, and so I just want to see if we have is too loose in the periphery. I'm going to select another lens with a tighter periphery for the patient, just to get started. Now, with the lens assessment, we want really important that you assess the lens within the first 5 minutes of application. So you don't want to put this lens on and send the patient out to the waiting area for 20 minutes. Evaluation, it's really important that you do assess this lens during that time point. So what is this MOROCCO VA technique? MOROCCO VA is the acronym that stands of movement, rotation, centration, comfort, and visual acuity, and all of them taken together create this dynamic assessment. So let's break this down to each of the step. We have got the movement. So where this lens is 1 to 2 millimeter of the movement, and you want to look at straight ahead gaze as well as up gaze. Note this is again. This is this gain this is gain a lot more movement than what we are used to seeing with our standard soft toric lenses, but this is what is considered ideal for Kerasoft IC lens. Next, we have a rotation. Again, this lens is stabilized with a prism palette, and so the lenses are marked. The right lens is marked with a vertical hash mark at 6 o'clock, and the left lens is interrupted hash mark lens. So it's really easy to see if the patient hasn't switched their lenses up when they are coming in with a problem. Now we want up to 10-degree rotation. Really, ideally, we want no rotation. We want that marking at 6 o'clock. If the lens is rotated more than 10 degree, and it's kind of locked on, so say it 15 degree or 20 degree, and holding steady between the blink up gaze, thus suggesting that the lens is fitting too tight. If we see that rotation mark is swinging with swinging, that is unstable rotation, and that's suggesting that the lens is loose. So the reason they call it a dynamic assessment, because while we are breaking this step down into MOROCCO, we are actually looking at them all together. So if I see some swinging rotation, I'm expecting that the lens is also going to be moving well over 1.5 millimeters, is probably more than 2 millimeters. So again, that is swinging movement, a swinging rotation with excess movement is suggesting that the lens is a pretty loose. Conversely, if you see minimal movement, you are not going to see that rotation moving, and unstable. It's going to be locked on somewhere, and traditionally, if the lens is too tight, you wouldn't actually see that marking at the 6 o'clock. Sometimes you will, but it may look at in different position. And different position and different position centration. It's obvious this lens has an 8 millimeter optic zone. One thing I will caution you with this lens is it's really important to take the housing of the SART map and put it directly in front of the patient, because when you change the angle of the light, you are going to see that the angle of the centration seem to be displaced. So again, the best way to observe this is with your housing directly in front of the patient's eye, and you would be able to really see that central optic zone is an 8 millimeters optic zone, and highlighted really nicely with the slit lamp. Comfort. This is pretty self-explanatory. It's a soft contact lenses. It should be comfortable for your patient. So when you insert a lens and the patient is uncomfortable, start suspecting that the lens is fitting a little too flat. Now, if the lens is dispensed to the patient and they come back complaining that there's area that get worse as the day goes on, then start suspecting that the lens is tight. Now, it may not be tight all the way around. It may be tight just in one sector. And this is another feature that we'll describe a little bit more later. That is, this lens has sector management controls. You can actually loosen up to or tighten if you need to sectors independent of one another using this lens design. The visual acuity, again, is a very straightforward. This is to me determine my base curve. So the visual acuity should be stable between the blink, and I will typically do a retinoscope and refine my refraction as long as I can get them seeing good enough. I'm going to put an isolated line on the chart, and I will just have them blink, and I want them to tell me if the vision stay the same between the blink. If the lens is fitting flat, it's going to be blurry because the lens is trying to find the home, and that is going to settle itself, and the vision will start to clear up. If the fit is fitting too stably, this is going to be well centered right after the blink and then drop off, and that's why the vision will start to get blurry. So if there is some instability of the vision, this is where I want to determine what type of instability they have, because for me, my best curve determination is based on the stability of vision between the blink, and like I said, we can change the periphery relative to the base curve, and we will describe more details. But for example, if the MOROCCO step so far are perfect, but say for instance the vision is clear and then get blurry, that is suggesting that the lens is steep, and if the MOROCCO steps are right in the good category, that may be in the peripheral curves that you want to for this lens. And then the base curve will be whatever provide the vision as and is visual stability. So when you would actually change the periphery independent for the base curve in those cases like the reverse geometry profile that you have, say for instance, I select the 8.6 standard lens for this particular patient here, so you can see that you would not be able to see this behind the slit lamp, but you can see just in theory that is this lens is too loose in the periphery. So what I would find is that my MOROCCO step may be indicating that the lens is too loose, so that the excessive movement, that rotation may be unstable, it may be a little decentered. So these are the things I'm thinking of. So, but before I would actually go to my fitting set and try another lens, I will I still want to double check the vision, and so in this case I assess their vision based on the baseline that they can achieve with the early overfraction. I do this particular lens for this patient would provide a stable vision between the blink. It's just the rest of the steps are not appropriate, and that is why we know that the 8.6 is the right base curve, but for some reason the fit is not appropriate, so we would have to try steeper lenses, and that's it. So you could actually try a steeper lens in your fitting set and see if it meets MOROCCO criteria ideally, or you could actually try the 8.6 steep to lens that is already in your fitting set. Lastly, we have the flat periphery situation, whether the lens may be ideal centrally for this deep nipple cone, but peripherally there's all of the space. And this situation, you may actually get a bubbles filling the space, and so the lens may be acting too tight. And this is why they have the 8.2 flat 2 lens in your diagnostic lens and in your diagnostic set. When it comes to lens care and handling for solution, you can use a bifro or any of the hydrogen peroxide system like Hydroxyclear for this. Lens removal, though it's a little tricky, this lens can be very slippery, so it's maybe a little hard to remove when you are first getting used to these lenses, but with a 6 and 12 technique, like how you would take a corneal GB lens out. So it's really easier to handle this lens using the 8 and 12 technique. Some fitting tips, the lens fit with a reference to the overall cornea shape. So we will be using some flat or base curve than usual. So that's why we have the set and the flatter base curve parameters. It's very important to evaluate the lens with the first 5 minutes. Also, if you do have a limited information about the cornea, you can start with an 8.2, a standard diagnostic lens, and based on the MOROCCO, you will know whether or not you need to go steeper or flatter. If you need more fitting lenses, that you have some advanced cases in the clinic, you need a steeper base curve in your set, or you need a flat. You need a steeper base curve in your set. You can order extra fitting diagnostic lens. So here, the end of my presentation. Thank you so much for your time and for your listening, and hope it was good enough for you. Thank you so much.